a lot of experience with. And again, if any questions throughout, just please send a message in the chat and we can keep it informal. So just firstly, disclosures, I have none. Okay. All right. So first, just a couple definitions. The term encephalopathy, it sounds kind of complex, but it's actually very, very non-specific. It literally just means brain disease. So really any brain disease could be called an encephalopathy. In practice, though, when we say encephalopathy, generally we're referring to usually a toxic or metabolic encephalopathy, which we'll go in detail shortly. Confusion, kind of non-specific again. It's defined clinically as an inability to maintain a consistent thought process. And delirium specifically is referring to confusion plus a component of hyperactivity of the sympathetic nervous system. This is, of course, in contrast to a hypoactive delirium. More often, the delirium is hyperactive and characterized by certain autonomic features like tachycardia, hypertension, possibly low-grade fever, diaphoresis, and pupil dilation. So that's general definitions there. Okay. In terms of the pathophysiology of a toxic metabolic encephalopathy, commonly there's abnormalities of electrolytes, commonly sodium, calcium, hypophosphatemia, cerebral edema from a variety of etiologies, including electrolyte imbalances, multitude of toxins and drugs, and also nutritional deficiencies or toxicities. Commonly here, you might think of thiamine for like Wernicke encephalopathy. Importantly, the whole point is there is a disruption in the milieu of the extracellular fluids around the brain. The brain is really, really sensitive to these little disturbances. You might even have perceived this yourself when you're, doing a night shift or, just working on maybe a double shift, and you ask a patient, "So what day is it?" And then you realize, oh my God, I don't even know what day it is. Is it the third or the fourth? If you look at your watch, that's a little taste of encephalopathy. Imagine that times 100, being in the hospital for numerous days, numerous medications after a stroke, and you can see how the brain is very, very susceptible to these changes in the milieu. Okay. So some clinical manifestations. Of course, starting with mental status, you might see people who appear agitated, more than just angry that they're in the hospital. They are pathologically agitated, very, very hard to redirect and calm down. As a maybe a helpful point for documentation, I'm sure many of you are used to writing things like ANO times 3. We in neurology generally like to be a bit more specific. The ANO times 3, I find a lot of teams use as meaning the patient is awake and they're talking to you, which is not ANO times 3. So it's oriented to yourself, the date, and where you are. And I like to write exactly what the patient says here. So for example, again, commonly you might ask the patient, what's today's date? And he or she might say, oh, it's September 7th, 2022. And you would say, well, not quite the 7th, but it's pretty close. I mean, technically you can write disoriented to date, but it's very, very different than a patient saying that it's like April 9th, 1976, right? So you want to write specifically what the patient says. Similarly, if they say, oh, I think I'm at like a Columbia Presbyterian, not quite disoriented to to place. Very, very different than saying that they're like in England, right? So write what they say. Disoriented to place one day could be very, very different from one day to the next, especially if the team changes, and one day off is very different than 10 years off. So write what the patient says. For some motor manifestations, you might have seen myoclonus, or these rapid jerk-like motions, which are with toxic metabolic encephalopathies often distributed throughout the body. These quick little muscle jerks, and often the patient is able to speak through this. So it's a form of generalized hyperexcitability, and not ictal per se, although ictal manifestations can present as myoclonus. And you might know that myoclonus can be triggered by any part of the neuraxis from cortex down to peripheral nerve. Toxic metabolic myoclonus, though, is a cortical phenomenon. And then asterixis, which is also called negative myoclonus. So this is where you would have a patient, for example, hold their hands out with the wrist extended, like to stop traffic. And you see this kind of a flapping motion. And here the pathology is the transient loss of tone. So the flap towards you is the tone being lost. Very commonly seen in toxic metabolic encephalopathies, often hepatic encephalopathy. Seizures are also very common. Seizures caused by electrolyte abnormalities themselves, or somebody might have underlying epilepsy or a focus of hyperexcitability in the brain triggered by the insults causing the encephalopathy. Tremor is very common as well, with a classic hyperactive delirium. This is in the category of an enhanced physiologic tremor. It's often a fine tremor. It's present during action and posture, and it's quite symmetric. You might see some emergence of prior pathology in the setting of toxic metabolic encephalopathies. For example, somebody with an old lacunar infarct, which they've healed quite nicely from, might reemerge in the setting of a severe electrolyte disturbance or urinary tract infection. It's a common stroke code in the ER. We get a scan, see an old stroke, nothing acute, so no TPA. And the autonomic symptoms we've already discussed. Okay. So just go over some of the etiologies we already touched on. So infection, systemic and/or in the central nervous system. So, classically urinary tract infections, pneumonia, sepsis, and with the CNS, of course, worrying about meningoencephalitis. You wouldn't necessarily tap everyone who comes in with toxic metabolic encephalopathy or just acute confusion. But if your initial workup is unremarkable, then you might want to consider a tap. Hepatic renal dysfunction, of course, talked about the electrolytes, glucose, hypo or hyper. Numerous medications, vitamin abnormalities, again, thiamine classically with Wernicke encephalopathy, toxins and hypoxia. So for the medications, importantly, the medication itself might have sedative properties, or a medication might interfere with the metabolism of another medication to cause it to be super therapeutic, and that might contribute to encephalopathy. So it's very, very easy, as you know, for patients to accumulate medications in the hospital for a variety of symptoms. And in general, you want to try to cut the doses and wean off as much as you can in the hospital if possible. All right, so just differential. Stroke can present and look like toxic metabolic encephalopathy. This is where a very careful neuro exam is very, very important. You might think somebody is confused, but actually it's not quite confusion, that's their aphasia. Or you might think somebody's acting quite psychotic, but that's not psychosis per se. It's from a right parietal infarct, which can present with psychotic features. So very, very careful neuro exam to look for acute ischemia. Seizure. Notably, non-convulsive seizures can present with confusion and agitation. So consider that if there's no other clear cause for encephalopathy. Migraine, complex migraine. So migraines can mimic strokes and sometimes seizures and a lot of other acute neurological problems. So consider that if a patient has a history of headaches. Other structural intracranial pathology, anything that might cause elevated intracranial pressure or even decreased pressure. Maybe somebody had a recent spinal tap and now has a low pressure headache, for example, and then they progress and become encephalopathic. Obviously, meningoencephalitis, traumatic brain injury, endocrine abnormalities can also present similarly, notably with thyroid dysfunction and cortisol imbalances. And of course, psychogenic etiologies. And with psychogenic, it's very helpful to get an EEG. If you're seeing somebody who's having what looks like a great posterior dominant rhythm and a reactive record, then you might think psychogenic's higher in the differential. Okay, so starting with the basic evaluation, basic labs. So everybody should get a CBC, CMP, a tox screen. By the way, even if somebody seems like they're endorsing a pretty accurate ingestion history of any substances, you still want to get the tox screen because sometimes whatever they took might have been laced with something else that they weren't even aware of. So just check that, and you'll never regret checking that. So I recommend that very strongly. A UAUC, blood cultures, ammonia, B12 level, osmolality, cortisol, and ABG. You wouldn't necessarily need an ABG and cortisol in everyone, but if the initial workup is unremarkable, I would get those next. Chest X-ray, look for a brewing pneumonia. Neuroimaging, here, if somebody has what looks like a mild delirium and a clear-cut cause, like they just started on a new sedative medication, maybe they have a new UTI, you wouldn't necessarily need a CAT scan. It's often done much more often than it has to be, but you don't necessarily need it. If there's a non-focal exam, the confusion is kind of minimal, and no other danger signs, then maybe you can avoid a CAT scan. Otherwise, start with a CAT scan, rule out anything acute. An MRI you would get if there's a new focal feature on exam, or if your initial workup is totally unremarkable, patient still altered, go for the MRI. Generally give them a couple of days to improve on their own. So, EEG is very helpful. It's cheap, it's non-invasive, so I recommend an EEG. Low threshold to get that, and an LP if your initial infectious workup is unremarkable, or there are like meningeal signs, or there's been a seizure. Okay, so because I'm an epileptologist, I thought I'd just go over just some basics of EEG with you. You might have seen this hooked up to a lot of people. So super briefly, here you have these leads. So this electrode measures the voltage. You subtract the voltage from this electrode and it gives you an output. If this minus this is negative, there's an upward deflection. If this minus this is positive, there's a downward deflection. It's all that it is. So in the normal EEG, let me just see, there's a chat question here. Oh, nothing, text event ID, okay. All right, so in any given chain with a longitudinal bipolar montage, which this is, you would normally have lower amplitudes and faster frequencies anteriorly. As you go posteriorly, you have higher amplitudes and slower frequencies. So this arrangement here is called the anterior posterior gradient, or the AP gradient. So this here, what you're seeing in these four channels, this is normal. And you see back here, we're seeing a nicely sinusoidal rhythm. This is called the posterior dominant rhythm. And in a normal healthy adult, you want this number to be at least 8.5 hertz. So you can see in each of the chains of the organization. So again, low amplitude, high frequency up here, high amplitude, low frequency down here in this chain. And then down here, it's the same thing. And then with each chain, you see the same thing. So this is a good EEG. What you're seeing in this section with the eyes open, this organization becomes a bit less organized. And then it emerges when the eyes are closed. So this is actually still normal, but the eyes are open. Okay. Next screen, there we go. So when you see slowing in an EEG report, this is what this is being referred to. So here you might see these slower waves. In between each of these long lines is this is 1 second. So now you're seeing here, which looks like 1, 2, 3, maybe even 4 hertz in certain areas. So the anterior posterior gradient has now been totally lost. You can see the frequencies and the amplitudes in the anterior channels are about the same as the posterior channels. So the organization is lost, and that posterior dominant rhythm we had previously, the nice 8.5 hertz, has been replaced by 1, 2, 3.5 hertz frequency. So, and you can see overall, it looks pretty symmetrically slow, which is classic for a toxic metabolic encephalopathy. As the encephalopathy deepens, the slower waves become more abundant, and they get slower and slower down to the delta range, less than 4 hertz. And deeper and deeper, there might be suppression of cortical activity, burst suppression, these bursts of mixed frequencies followed by suppression, and eventually even just suppression or no activity at all. So that's the general progression. This is another thing you might see in a lot of EEG reports. It's called GRDA, or generalized rhythmic delta activity. So this pattern here, when a broadly distributed and symmetric, is not an ictal pattern. It's just generally non-specific and points to a diffuse or multifocal dysfunction. It can also be seen normally in during hyperventilation and in some older adults during drowsiness. So this is normal, and to qualify as this pattern, it has to occur for at least 6 cycles. But this is a common finding. If this finding down here were only here, and it was not present on this side, the left side, then it might represent a hyperexcitable pattern, similar to, you might have heard of PLEDS, or lateralized periodic discharges, it could indicate an underlying area of hyperexcitability or seizure potential. But when broadly distributed and generalized, it's just an encephalopathic pattern. Okay. You might have heard of these things called triphasic waves. There's numerous names just to confuse you. They're also called triphasics or generalized periodic discharges with triphasic morphology. So these are seen in a variety of metabolic encephalopathies, classically hepatic, but they can be seen really with anything. So the characteristic features here, you see here how a discharge anteriorly, how as time goes on, there's a bit of a lag, right? As time is moving on. So this is called an AP lag, anterior posterior lag, classic for triphasics. 3 phases you have here. You have up, down, up. So remember, up is a negativity, down is a positivity, and up is a negativity. So boom, 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 triphasic. These often occur at approximately 2 hertz. And if you give a benzodiazepine, these can attenuate, which does not mean it's an ictal pattern. One little pearl is that even though these are more often seen in metabolic encephalopathies, they can represent an ictal pattern if they are evolving in morphology, frequency, and/or location, and associated with what looks like a clinical ictal seizure. So these are not totally benign in every single circumstance, but more often than not, they are. Okay. So management, of course, for anybody coming in who's altered, giving thiamine is never a bad idea prior to giving glucose to avoid precipitating Wernicke's encephalopathy. Correcting underlying disturbances. I should mention the improvement in the encephalopathy, it usually lags behind the resolution of the disturbance by roughly several days. It can happen pretty rapidly, for example, with correction of hypoglycemia, but with things like renal, hepatic encephalopathies, commonly the nephrologist would say, hey, they just got dialysis, why are they still altered? The brain doesn't quite bounce back like that. It takes a bit longer, especially in somebody who's been in the hospital for several days in a row. Of course, hospital delirium is its own risk factor for encephalopathy without any metabolic disturbances whatsoever. So there's usually a lag for a couple of days. And that's the general guidance I give to teens when consulted for an encephalopathy without focal features. I would say, after you you treat their UTI, after their creatinine improves, wait a couple of days, see how they're doing. If not better then consider getting an MRI and/or an LP. And then rarely you will see an embolic shower or something, but we don't just jump to that immediately. So you want to give redirection as frequently as you can. And again, reminding somebody what the date is, where they are, what's going on. I like to also remind my patients why they're in the hospital. They often have just no idea. And you want to keep on doing this because they might forget, so each day during rounds, say you're in the hospital, there's been you had a seizure, it could have been provoked by some electrolyte imbalances, and here's how we're treating you, and here's what's going on. And you might have to tell them later that day, and that's okay. You want to avoid restraints if possible. That can often worsen delirium. It can contribute to injury. It seems paradoxical, but that's what happens very frequently, unfortunately. If possible, try to have a bed at the window so they can see sunrise and sunset to help maintain a good sleep-wake cycle. Regarding the sleep-wake cycle, of course, easier said than done to get sleep in the hospital, but the more sleep they get, the better. And avoiding sleep aids is also preferable. Again, less medication, is better. I tell patients who can't fall asleep that, trust me, you will fall asleep at some point. Any sleep aids I give can contribute to encephalopathy. So while in the hospital, it's uncomfortable, but they'll get out eventually. They'll feel much better when they get home sleeping in their own bed. Okay. Any medications with sedative properties, remove if possible. And not only that, but any medications, period, that aren't totally necessary. Recall what I said about interfering with the metabolism of other medications, which could be sedative, and with polypharmacy can combine to produce encephalopathy. Of course, considering the risk and benefits of additional days in the hospital, we don't want to get people out too prematurely to avoid bounce backs, but every day in the hospital is not only risking, UTIs and DVTs, but also hospital delirium. So if you don't absolutely have to stay, it's maybe better to get out on the sooner side. If there is a severe agitation or psychosis, and redirection is not working, then you have to rely on some medication sometimes. So like haloperidol, tiopein, risperidone, or olanzapine are go-tos. And then make sure to not have these as just generally standing. You want to use these sparingly and only if possible. Redirection is really, really the best thing. Okay. So the prognosis is really dependent on the underlying etiology. Somebody who has, who's dialysis dependent, overall their prognosis is terrible, despite even having a mild encephalopathy, versus somebody who has maybe a severe encephalopathy in the setting of a very bad hypoglycemia, getting the sugars in balance, they could be totally fine. So it really depends on what's actually causing the problem. In general, though, there is an increase in mortality in somebody with a toxic metabolic encephalopathy, which is probably not too surprising. Recovery can occur over minutes, again, with things like alterations in glucose acutely, to months, and sometimes over a year, which is rare, but this can be a bit longer to bounce back in somebody, for example, with dementia, multiple strokes, other neurodegenerative disorders like Parkinson's disease. But most often, the patient improves within a couple of weeks. So generally, the prognosis is fairly good. Okay, wow, sped through. So there's maybe some more to talk about, but maybe any questions for anything I've touched on so far?
Type them into the chat, guys, if you have any.